Good afternoon, ladies and gentlemen. My name is Dr. Shamsuddeen Yahaya. I'm the Executive Secretary, Katsina State Primary Healthcare Agency. This is an agency that coordinates all primary healthcare activities in the state. Katsina State has a total population of over 10 million people. We have a lot of services. We have primary, secondary, and tertiary. The primary healthcare agency coordinates all activities at the primary healthcare level. So we conducted this study, community-based health management information system, causes and distribution of maternal deaths in high death settings of northern Nigeria. Just like what my colleague has presented, he was focusing on the neonatal aspect. I'm going to talk about the maternal component. I'm going to follow this outline. And this is Nigeria accounts for the highest burden of maternal death globally, and majority of events occur outside the health facility. Just like what my colleague has said, we feel that let us have a look at what is happening outside the health facility. We have a population of over 200 million in Nigeria. We have 36 states. And life birth of over 7.5 million people. You can see from the map, the red area denotes areas where we have very high maternal mortality rates, while the yellow aspect has the high maternal mortality, while only a smaller part of the states have the moderate mortality rates. And 30% of all births and 10% of all deaths are registered in Nigeria. And so we feel that we should have a system to know what is happening really. And also approximately 82,000 deaths occur for women every year. So these are some of the terms. I'm not going to repeat them. My colleague has mentioned some of them. But we know that maternal death is the death of a female from any cause related to or aggravated by pregnancy or its management, excluding accidental or incidental causes during pregnancy, childbirth, or within 42 days of termination of pregnancy, irrespective of the duration and the site of pregnancy. So the objective of this study is the aim of this study is to identify causes and distribution of maternal deaths using the community-based health management information system platform in Katsina State, northern Nigeria. And the specific objective is to generate community maternal mortality data utilizing the CBHMIS and IDSR platform. IDSR is the Integrated Disease Surveillance and Response platform. We also want to determine the burden and causes of distribution of maternal deaths in 5 local government areas of Katsina State. We picked 5 out of the 34 LGAs, and the last objective is to utilize the study findings to address the drivers of maternal and neonatal mortality in the state. So this is the methodology is similar to what my colleague has spoken, which the study setting was conducted in Katsina State in 5 local government areas, and the design is mortality reviews using the verbal autopsy and physician-certified verbal autopsy. So these are some of the findings. We have recorded a total of 1,151 mortalities, and the 716 of these deaths occurred at home, while 435 occurred at the hospital. So the 62% of all maternal deaths occur outside the health facility. This underscores the importance of looking at what happens in the community. So this is the trend by month of maternal mortality. You can see it with the peak occurring around July 2024. So again, Katsina local government is the metropolitan LGA, and it has a lot of other smaller LGAs. And in the state, we have a lot of insecurity, and a lot of other insecure LGAs are displaced. We have a lot of internally displaced people. So perhaps that contributes, and we have a lot of urban slums. So Katsina has the highest number of maternal deaths, which are 542, followed by Kaita and the others. So these are the deep dive look at the what political words contribute to the highest mortality. We've been able to look at Kudu 3, Gabas 2, and others that contribute to the highest number of maternal mortality. So looking at the age distribution of these mortalities, the age group 25 to 29 has the highest number of deaths, accounting for 27% of these deaths, with the mean maternal age at death as 31.4. So because we are looking for us to calculate our denominators for maternal mortality, the maternal mortality ratio, you need to have live births. So you need to know the total number of live births. So during the 12-year period, we've recorded 77,185 live births in the study setting, with 65% of the live births occurring at home, while 35% in the hospital. So this is the, we have a maternal mortality ratio of 1,491 per 100,000 live births. So this is much, much higher than the national average of about 500 maternal mortality. We have huge disparities between the northern and southern part of Nigeria, mainly due to some of these factors. A lot of social determinants are contributing to a lot of maternal mortality in Nigeria. Sociocultural factors, poor socioeconomic status, deeply rooted beliefs, lack of access to, family planning services, and so many other factors. So that is why this picture is happening. So this is the, for every LGA, we also went down to look at the average maternal mortality ratio that is contributed by various LGAs. Still, Katsina local government is contributing the highest with over 2,000, followed by Mani and the rest. So these are the commonest causes of maternal mortality in the study area. Obstetric hemorrhage, accounting for over 40% of the causes of death, followed by hypertensive disorders of pregnancy. We have maternal sepsis, malaria in pregnancy, and prolonged or obstructed labor, accounting for 12.2%. And we have abortion-related complications. So these are the main causes of maternal mortality in the study area. So we can see that we also have other causes that the remaining 5% is due to obstetric death unspecified. We have anemia, complication, septic abortion, asthma in pregnancy, diabetes in pregnancy, and others. So these are the remaining causes. The earlier slide that I projected, these ones account for the 95% of all causes of maternal deaths. If we can address these 6 leading maternal conditions, then we'll be able to address at least 95% of the causes. So in conclusion, the maternal mortality ratio in the study setting is substantially higher than the reported national average, which is about 580 or so. Over 90% of deaths were attributed to the leading causes of obstetric hemorrhage, maternal sepsis, hypertensive disorder of pregnancy, obstetric labor, malaria, and abortion-related. Focusing solely on hospital-based interventions may not dramatically reduce the maternal mortality ratio, given that most births and deaths occur outside the hospital setting. So these are some of the recommendations and implications to practice. We need to create awareness and demand for maternal health services to reduce the type 1 and type 2 obstetric delays. You know, we have 3 types of delay that are related, or 4 types of delay to maternal mortality. Delay in taking decision to go to the facility to deliver, delay in reaching the hospital to get service, then delay at the facility, maybe due to lack of essential equipment or human resource, then delay in even coordination. We have added another delay in response to the maternal death. We need to institute community-based interventions such as misoprostol and post-delivery kits distribution to promote facility delivery. Perhaps if we can provide these services, it will encourage the women to come to the facility to deliver. We need to expand the coverage of health insurance to improve uptake of sexual and reproductive, maternal and newborn child health services. This will address financial barrier to health services because people there are predominantly poor. Maybe they feel that going to the facility, they will spend money. By the time we expand health insurance, it will go a long way in addressing that. There is need to advocate for policymakers to adopt the maternal and perinatal community-based surveillance and response to address the high level of maternal mortality. We need to be taking stock of any death that happened. We need to investigate and know what is the cause with the view to providing solution to that. We need to advocate for the continuous funding and usage of community-based health management information system platform for routine mortality tracking and underlying cause of death determination to bridge the current gap of community mortality data generation and use. So we also need to strengthen emergency transport scheme to address the second cause of delay, and we need to recruit and deploy more skilled birth attendants to provide obstetric services while focusing on capacity building efforts targeting the leading cause of death. We need to ensure the availability of life-saving maternal drugs and equipment, especially seeing that obstetric hemorrhage is the leading cause of maternal mortality in the study setting. These are some of the limitations of the study, which my colleague has mentioned them earlier on. So these are the group of our physicians that were responsible for the verbal physician certified verbal autopsy. This is my reference. Thank you very much.